Thank you for the opportunity to speak this morning. As mentioned, I'm Trevor Crafts. I'm the Minimally Invasive Surgery Fellow at Endeavor Health, or formerly North Shore, and presenting today on a feasibility study, essentially a case series of patients with a novel endoscopic procedure, which we have titled POPE, or Pore-Oral Plication of the Esophagus. Our principal investigator is a consultant for Apollo Endosurgery. Otherwise, none of the other authors have any relevant disclosures. So the POPE procedure seeks to address two convergent problems. One, the end-stage esophagus of achalasia, and two, the gastric conduit with delayed emptying after esophagectomy. And these problems are characterized by dilated, defunctionalized structures. And even after treatment of outflow obstruction, whether it be dilation, stenting, or myotomy, in some cases the organ still cannot propel food contents distally. And although these are distinct disease processes, in both cases the structural distortion caused by long-standing disease generates a sort of a sump process, whereby emptying can't take place. And so the thought behind POPE is that perhaps by plicating the tissue, one might restore the original form by sort of retubularizing the organ, thereby improving its ability to empty, if only with the assistance of gravity. So we do this procedure under general anesthesia with the assistance of an overtube. And we begin by identifying the redundant or sump portion of the esophagus. And using an endoscopic suturing device, the tissue is captured with a helical probe and delivered to the jaws in order to drive a running 2-0 permanent monofilament suture through. We perform sutures in a running U or V shape, usually with about 6 plication bites before deploying our cinch, much like an endoscopic sleeve. This is repeated as many times as needed to mitigate the sump and until the desired effect is achieved. And so you can see here at the final pass, the conclusion, the caliber of the lumen is substantially reduced and the sump is eliminated. And patients are actually able to go home the same day. So we looked at our institutional series of patients who underwent POPE or a repeat POPE procedure from 2019 to present. We collected clinical data before, during, and after the procedures to evaluate 90-day outcomes. And additionally, we collected quality of life survey data over the phone at kind of regularly scheduled interval follow-up. 8 patients in our series had end-stage achalasia. Interestingly, manometric data for all of these indicated type 1 achalasia, with the exception of 1 patient. 5 subjects had delayed emptying of a gastric conduit, and there were no significant demographic differences between our two groups. And you can see here on the right a summary of prior interventions for both groups. So we found that the procedure is able to be performed rather expediently, with an average duration of about 75 minutes to complete 3 running sutures. Median length of stay was 0 days. In 90-day follow-up, none of our complications were directly attributable to the procedure itself, but 4 patients with gastric conduits ultimately had essentially procedural failure with recurrent outflow obstruction. So the difference between these two groups was then, of course, statistically significant. Of the 4 procedural failures, 2 of the patients were readmitted with aspiration pneumonia requiring antibiotics. 3 ultimately required pyloric stenting, and 1 of these unfortunately had a delayed perforation of the stent. And then final patient ultimately had to be laparoscopically, his conduit had to be mobilized and pexied to the abdominal wall. So, and then we had 1 achalasia patient who was seen in the ED the day after the procedure for pain and discharged uneventfully. And our overall median follow-up was 20 weeks. So at initial follow-up visit, roughly 2 to 3 weeks after surgery, symptoms had improved or resolved in the majority of our patients, with achalasia patients having a more reliable outcome. We would highlight that since the introduction of the procedure at our institution, no patient has required an esophagectomy for achalasia, nor surgical replacement of a conduit. We do note that eventually 4 patients, as I mentioned, went on to have recurrent symptoms and ultimately required a repeat procedure. When we surveyed patients regarding their satisfaction, there was a continued favorable response that remained durable through 3 years. Here, obviously, lower scores indicate higher levels of satisfaction, and results reached statistical significance at 3 weeks, 6 weeks, and 3 years postoperatively. There are some favorable trends in the remainder of our quality of life data. However, the utility of this is really not yet interpretable. Total sample size for these data at later time periods is extremely small due to the recency of our procedure, and accordingly, the results don't meet statistical significance. So the limitations of our study, obviously this is a study with a small sample size and relatively limited follow-up in terms of what are otherwise chronic disease processes. And additionally, there are no yet standardized imaging metrics to assess or follow an objective response in these patients. So in conclusion, endoscopic organ plication with POPE has the ability to mitigate the sump phenomenon seen in these patients, and seems to be safe and effective for the treatment of end-stage achalasia, potentially even obviating the need for esophagectomy. And while this procedure may be suitable for patients with gastric conduits, they certainly have higher rates of treatment failure. And so with that, I want to thank the following individuals and the Endeavor Health Department of Surgery. I'll take any questions.